Great, thank you. Fred, if you could please introduce yourself. We'll start by introducing ourselves, or you could please introduce yourself.
So my name is Fred Desjarley. I'm from Red Lake, and here at NACC is Elder in Residence Spiritual Care. Good to see everybody today.
Thank you, and Michelle.
Hi, everybody. Welcome. I'm Michelle Corcoran. I'm the nurse manager for the MAT program at NACC.
Nikki.
I'm Nikki Jardina. I'm the infectious disease nurse at NACC.
Dr. Gail, I just see you here. If you wouldn't mind introducing yourself.
You bet. I'm Dr. Gail Mason. I am the behavioral health director here at NACC.
And Tina.
I'm Tina. I'm the HIV non-medical case manager.
Thank you. And I'm Kari Rabi. I'm the medical officer and also addiction medicine and family practice physician here at NACC. Okay, if we could just start the slides. So welcome to the Midwest Tribal Echo, where we have a presentation today by Sarah Gordon. She's going to be talking about tuberculosis. So we're glad to have her here. Next slide, please. So this is our agenda. We've had our prayer and land acknowledgement. I'm running through the introductions and agenda. We'll go through Zoom guidelines. Tina will do the announcements. Then we'll have Sarah Gordon do her presentation. If time permits, we have a case presentation, and then we'll close. So Zoom, we kind of all know Zoom a little better than we did 2 years ago, but yes, please introduce yourself in the chat function, your name, title, organization, email. We can use this for CME. You can update your name on the screen by right-clicking on the image and renaming. Feel free to eat while you're with us. We do prefer that you turn your camera on. It's just much easier to have a conversation if you do that. Also, please mute your microphone when you're not speaking. If there's noise coming from your square, we may mute you. Please don't be offended. And you can use the chat or hand raise function if you need attention. And as always, please no protected health information on these conversations. Tina?
So just as a reminder, we meet every first and third Wednesday from noon to 1 p.m. Our next ECHO session will be May 4th. And it will be Dr. Rabi talking about MAT and buprenorphine. So some other echoes happen. There's a cool limited series echo coming up that starts May 2nd. It's just going to be every Tuesday in the month of May, and it's hosted by the Northwest Portland Area Indian Health Board. And the topic is ending the epidemics in Indian country. And that requires registration. So if you want registration for that, please let me know and I can forward that to you. Hennepin Healthcare hosts a couple of echoes. There's an integrated opioid and addiction care echo and a viral hepatitis echo. There's also this thing called the Indian Country Echo, which is based on the West Coast, but they host a really wide catalog of topics, and you can watch past presentations or register for upcoming ones. And then Stratus Health, who is our partner, they also host another echo called Opioid Use Disorder Education and Treatment Echo with Dr. Heather Bell and Kurt Devine. And we also have an MOUD treatment virtual boot camp that is recorded on YouTube. It's a few hours, but you can just kind of watch as you're able. So if you want information about any of these, please just let me know and I can email them to you. Case presentations usually happen at the end of each echo session if we have time. And this is a great way to bring real life concerns or like patient scenarios to the table, and we can kind of talk about them together and learn from each other. So if you have a case presentation that you want to bring to this echo, please just reach out to me and I can get that started. Continuing education credits are available for this session. You'll just need to complete the survey that I send out after the session. So just as a reminder to please introduce yourself in the chat and provide your email address so that I can get that survey to you. That would be great. And I'm going to stop sharing and pass it over to Sarah now.
Okay, and Tina, did that work?
That works, yep.
All right, thank you so much. So thank you for having me. My name's Sarah Gordon. I'm the supervisor of our TB control program at the Minnesota Department of Health. And before I begin, I would just like to do a land acknowledgement. I want to acknowledge my truth as a descendant of Nordic settlers. Today I work and live on ancestral lands of the Dakota people. I not only want to acknowledge the Dakota, the Ojibwe, the Ho-Chunk, and the other nations of people who also call this place home. I pay respect to their elders, past and present, and consider the many legacies of violence, displacement, migration, and settlement that brings us together here today in our work. So our objectives today, just a basic understanding of the unique history of TB and its disease pathology, differences between latent infection and active disease, signs and symptoms, the evaluation, treatment, and the role of public health in TB control, epidemiology, and just a little bit on contact investigations and genotyping. And there'll be hopefully room for some questions at the end. So history. So the genus Mycobacterium, it may have originated 150 million years ago, and one of those sublineages is tuberculosis. It's a very ancient disease. We found skeletal deformities in mummies that are very typical of TB, dating back to 2400 BC. The personal physician of the Roman Emperor Marcus in 174 AD described the symptoms of TB with fever, sweating, coughing, blood-stained sputum, and recommended the treatment of fresh air, milk, and sea voyages. And little did we know that that treatment of fresh air would continue all the way to the 1950s. TB has been known as the king's evil, the white plague, consumption. And it wasn't until 1882 where Robert Koch, in that little picture right there, identified and isolated the tuberculosis bacillus. So from the 1600s to the 1800s, TB caused 25% of all the deaths in Europe. During the 18th century, Western Europe became endemic, with a mortality rate as high as 900 deaths per 100,000 people. It was known as the robber of youth, as in the Industrial Revolution spurred TB spread due to problematic social conditions, the deprived work settings, extremely overcrowded housing, primitive sanitation, and malnutrition. From 1838 to 1939, a third of all English tradespeople and employees died of TB, compared to only a sixth of the upper class of that time. The same conditions led to a rapid spread in America's working class, with poorly ventilated factories and tenement-style housing. In 1908 was the development using technology to diagnose TB that is over 100 years old. It was not until 1951 where we had the drug isoniazid, 1952, the drug pyrazidamide. 10 years later, we had ethambutol in 1961 and rifampin in 1966. So it wasn't until 1966 where we had our 4-drug frontline regimen that we use today to treat pan-sensitive tuberculosis. By the beginning of the 19th century in America, TB had killed 1 in 7 of all people that have ever lived. The victim suffered from hacking, bloody coughs, debilitating lung pain, and fatigue. It's a gruesome disease to die from. By 1990, Native Americans had the highest mortality rates from TB, as the residential schools and crowded reservations just became hotbeds for TB spread. In 1854, we had a doctoral dissertation by biology student Herman Bremer, and he described healing his own TB after travels to the Himalayan mountains. And this became the sanatorium cure. So think back to that fresh air that the Romans used. This became the standard treatment all the way through the 1800s, actually all the way up to until 1950. So throughout the 1800s, TB patients sought that cure of rest and fresh air. And although people still didn't quite understand that TB was an airborne disease, the nature of creating these sanatoriums where people could go live and be cured from their TB actually helped reduce TB in the general public because it just helped contain that ongoing spread. So I'm just going to go quickly through some pictures here. We've got a photo of a sanatorium, and you see the beds on the porch outside so people can get that fresh air, hopeful cure from TB. This is the Jewish Consumptive Relief Society Sanatorium in Lakewood, Colorado. Here's the Minnesota Sanatorium for Consumptives, the Agua Ching in Walker, Minnesota. 20,000 Minnesotans died between 1889 and 1899. Here's a picture of the Sandhaven State Hospital in North Dakota. These grounds were purchased and reclaimed by the Turtle Mountain Band of Chippewa in 92. We have the South Dakota State Sanatorium in Custer, South Dakota. Here's a very modern ambulance of its time in 1908, taking a TB patient to the hospital in Minnesota. The St. Paul is the St. Thomas, or the Thomas Hospital for TB patients on 6th Street in Minneapolis, not in St. Paul, sorry, this is 1941. And here's a great public health poster from the 20s that say, if you don't have open air playgrounds for children, your city is going to be responsible to open up its own tuberculosis sanatoria. So again, fresh air cure. And here we all are at MDH compiling data in 1938 by hand on our little index cards of TB case reports. So here's a great graph that shows that steady decline in cases, and you can see where the red arrows are is that effective treatment. So that combination of having TB patients go off to live in sanatoriums and then that effective treatment during that decade really reduced TB cases in Minnesota and in the United States. And you can see we've been a steady decline all the way to March 2020 when we had our first case of COVID diagnosed in Minnesota. So let's get into what is this thing called Mycobacterium TB? It's a bacteria. It's spread airborne, so it's this droplet nuclei that you can inhale if someone around you who's infected is coughing, sneezing, singing, talking. And when you breathe that in, you kind of go through two phases of TB. And the first is latent infection. And then that second phase is TB active disease. And TB is most commonly found in the lungs, but it actually can be anywhere in the body. So that's an important piece, because only if it's pulmonary in the lungs or laryngeal in the throat can TB be infectious to other people. So that first stage is latent. Your body actually, if you can see in the corner of that lung picture, when you breathe in the bacteria, your body kind of builds a little cocoon around those TB bacteria germs. And it holds it in place. It's dormant. It's not active. You don't feel sick. You don't have symptoms. You definitely can't spread it to other people. And you can get it treated in this phase just with 1 or 2 medications. It's a shorter treatment regimen than active disease. And it actually really lowers your risk, your lifetime risk of ever developing TB down to about 1 to 3% at most. Now, if you progress in your TB disease and that latent infection kind of gets reactivated, we call that active TB disease. So those cocoons open up, that bacteria starts growing, multiplying, replicating, and then people start feeling sick. They usually have symptoms, and if they're infectious, they can spread the germs to other people. And for pan-sensitive TB, it's that frontline treatment regimen of those 4 drugs. So with latent TB, you should have a positive skin test or a positive blood test called the IGRA. Latent infections, not yet reportable in the state of Minnesota. Treatment can prevent progression to active disease. And just keep in mind, 1/4 of the world's population has latent TB. The prevalence of TB globally is absolutely huge. Only 30% of people exposed to TB actually develop latent TB. So TB is not super easy to get from somebody. It actually requires pretty consistent, ongoing, regular exposure of a considerable length of time. So we most often see transmission in households, but not beyond that. So what about that 10%, the 10% of people that go on from latent infection to active disease? And often we see that there's something going on with the immune system where it can no longer control that latent infection and handle whatever other health condition is going on. So we see a lot of progression in folks who have diabetes, especially untreated diabetes, HIV or AIDS, kidney disease, being infected within the last 2 years. So when you're first infected, those 2 years, you have a very high risk of your body just not being able to control this, and you go straight into active disease. A weakened immune system. So certain cancers, immune suppressing medications like steroids, other medical conditions, even advanced age, substance use, smoking cigarettes, malnutrition can all factor into a higher risk of progression to active disease. HIV is a danger zone with TB patients because HIV actually, people have a 10% annual risk of developing active TB disease when they're living with HIV. And what does TB look like? It's that prolonged cough. We're talking like 3 weeks or more, severe night sweats, fevers, just really feeling tired or weak, that general malaise, hemoptysis, that coughing up of blood or brown colored materials, poor appetite, chest pain, chest tightness, chills, and unintentional weight loss. And that unintentional weight loss is where that term consumption came from. If we have a positive test, we look at a chest x-ray. If there's pain in other parts of the body, we'll do a tissue biopsy. There's sputum testing, so what someone can actually productively cough out of their lungs. And if someone's symptomatic, really looking at chest x-ray or CT scan abnormalities. And then when we take that sputa, we want to get 3 good sputum samples, and we're actually looking for the TB bacteria in the sputum sample. So if somebody's coughing up and we can see the TB right there, that's called a smear. Positive smear usually indicates someone's pretty darn infectious. And then we take every isolate and we culture it out. So even if we can't see it right away, we take it out for culture to make sure that we're not missing anything. Now let's go in globally. We have about 10 million new cases of TB every year. We have about 500,000 of those cases are either rifampin or have multi-drug resistant strains. TB is one of the top 13 causes of death worldwide, and it is now the 2nd leading infectious disease killer. COVID-19 took its place. It is the leading infectious disease killer over HIV. A lot of people don't realize that. Of those 10 million people who fell ill in 2020, 1.1 million of those were children. Another 1.4 million died from TB, including 250,000 people living with HIV. This is the first year in 2020 that TB deaths have increased since 2005. And we really suspect that the COVID-19 pandemic has just reversed years of progress in reducing TB mortality. Drug-resistant TB, especially multidrug, it remains a public health crisis and a global security. Only one with drug resistance to access treatment 20, which just more effects of the pandemic. So let's talk a little bit more about drug-resistant TB. So one, treatment of latent infection reduces the risk of active disease by 90% or more. Treatment of active disease is usually 4 to 6 medications for a course of 4 to 24 months. So it really depends on where the disease is and the level of drug resistance with the right treatment regimen that we use. That's why getting treated correctly for the right amount of time the first time is really so important. And you can just see how your drug treatment increases with drug resistance. The consequences of multi-drug resistance are huge. It soars costs. The antibiotics become less effective as they become more toxic. We have increased treatment failure, death, longer and more expensive treatments, and just that specter hanging out there if we keep getting so much drug resistance of TB in the world that we're going to reach a point where we have untreatable tuberculosis. I want to cover some epidemiology here locally in Minnesota. So numbers went down in 2020 nationally. So we have our highest states with TB incidents are Alaska, Hawaii, California, then Texas, or actually New York, then Texas, New Jersey, Maryland, and the District of Columbia. And that New York number is primarily New York City. The bulk of our TB cases in the United States really come from just 4 states: California, Texas, Florida, and New York City, or New York, which actually is New York City. If you take New York City out, New York State rates are very low. When we look at TB in Minnesota, as you can see by the map, the bulk of our TB is in the metro area. That makes sense. It's where the bulk of our population is. Ramsey and Hennepin County, and then the surrounding suburbs, the St. Cloud area, as you can see, usually has the highest rates of tuberculosis. Here's our trends going from 2001 to 2020. We had 117 cases in 2020. The nation had 7,164 cases. So our rates are fairly still low in the United States compared to the rest of the world. There is an upward trend from 2015 to 2018. And then we've had a slight decrease that continues from 2018. So we're already seeing our case counts go back up. We had 134 cases last year. I suspect we'll be close to that or exceed that for 2022. Again, we had this effect of the COVID pandemic on TB. So we're looking at a combination of either a true decline in cases with people staying home, the wonderful use of masks, but we also have seen TB being underdiagnosed, and we'll see the effects of that over the next few years. Here's our incidence rate. The national rate in 2020 was 2.1. Minnesota was 2.2. This year, we're both kind of around 2.4. Often we're below the national rate or a little bit above the national rate. When we look at TB incidence by race and ethnicity, you can see our largest populations here. The top line with the light blue with the triangles, that's our African and African American group. Below that would be our Asian and Pacific Islander group. And there's a very good reason why those two stand out on top. Below that, toward the bottom, we have kind of our Latina group, all races and ethnic groups, and Native Americans. We have not had any cases since 2018, although that has not been true in prior years. So when we look at the bulk of TB, of course, comes from endemic countries. So when we look at the proportion of TB cases born outside of the United States, in Minnesota, our rates are right around 90%, which is higher than the national average. The main countries of birth for our TB patients rank with Somalia, then Ethiopia, Laos, but that is actually majority is Hmong, so it's Laos via being moved due to war. Then India, Vietnam, and we see, that is a big chunk under other. We actually see cases from 51 different countries here in Minnesota. And then, so we have nationally, the top 5 looks a little different. So the top 5 nationally is Mexico, then Philippines, India, Vietnam, and then China. I'd like to just get into a little bit of TB surveillance and care. So this slide, as I said earlier, TB can be anywhere in the body. And people can have pulmonary TB as well as extrapulmonary TB, which means outside of the lungs. But keep in mind that the bulk of our TB is pulmonary. So the majority of our TB has the potential to be infectious and then transmit and cause other cases and outbreaks. So when we look at our main ways of finding cases, so how cases were identified in Minnesota, an overwhelming percentage is people coming in with TB symptoms. That's 81%, followed by TB contact investigations, our overseas TB class follow-ups for refugees and immigrants, domestic refugee exams, other immigration exams, employee screening, targeted testing, and then the incidental chest X-ray or lab result. When it comes to public health or just the groups involved in TB, there's a lot of work that goes into TB care and control. At the national level, you have the CDC, the national labs, the Centers for Excellence, professional orgs, activist groups. At the state, you have your TB programs like the MDH TB program, our state lab, and we always have a state medical consultant. Just because TB is not a super common disease, we always want to make sure that people have access to medical consultation when they're working with TB patients. And at the local level, you have the real heavy lifts. So you have the county nurses, EPIs, and outreach workers, the community nurses, such as clinics like yours at NACC, the county TB clinics. We have 3 TB clinics in Minnesota, and our local healthcare systems. So the public health role is everything from patient to contact investigation, making sure that patients make it through those, 4 months all the way to 2 years of treatment successfully, doing community awareness and engagement, providing expert medical consultation, medication access. All the TB meds come through the state health department for TB patients. And most importantly, I think, is DOT, which is directly observed therapy. So every single TB patient gets their own local public health nurse who makes sure that they get treatment and are doing okay every single day. And I'd just like to talk briefly about domestic TB transmission. So a TB case is designated as attributed to recent transmission. So keep in mind that, 90% of our TB cases actually are in people who are coming from endemic countries. So you always have people who are progressing to active disease and develop TB. And then we're talking about this group of TB spread. So determining what is recent transmission in Minnesota and the United States, and honing in on that to control TB, and that is found through contact investigations. And this is part of our bigger picture of trying to control for TB outbreaks. So when we look at recent transmission, we need to determine if there's a plausible source case can be identified with someone who has the same TB genotype, has an infectious form of the TB disease, resides within 10 miles from the TB case, is aged over 10 years, and has received the TB diagnosis within 2 years before the case. And then CDC defines extensive recent transmission, which is the shaded area with the green dots, as meeting the criteria for recent transmission and at least 5 other cases, including the source, have received the TB diagnosis within 3 years before the case in the same assumed chain of transmission. So we're getting at how CDC defines outbreaks. So in other words, we are seeing a cluster of cases or even an outbreak associated with a source case. And about 10% of our cases are from recent transmission, and about 5% of our cases have led to a cluster of cases or even an outbreak. The factors associated with recent transmission include experiencing homelessness, a mental illness, substance use, being a US-born case, and having a delayed diagnosis of TB. And that can be from the patient being symptomatic but not seeking healthcare, or a provider actually missing that diagnosis. So the distribution of risk factors for TB investigation and progression to active disease, they greatly differ by place of birth. So you can note that a patient can have multiple TB risk factors. Among TB cases reported in Minnesota from 2016 to 2020, patients born in the US were more likely to have been a contact to an infectious disease patient within the past 2 years, or have a history of travel to an endemic area, have a history of substance use, have experienced homelessness within the year prior to the TB diagnosis, have been incarcerated within the last 5 years at the time of diagnosis, or have resided in a long-term care facility at the time of diagnosis. Non-US born cases, on the other hand, were more likely to be co-infected with HIV, were more likely to have worked in a healthcare setting, and only 11% of healthcare personnel TB cases were identified through that healthcare personnel TB screening. No cases among healthcare personnel were attributed to occupational exposure. So it's been personal risk. So we have some tools that we use to help detect recent transmission. So of course, our case reports, doing contact investigations is key, which are establishing the social and geographical locations called epilinks, doing whole genome sequencing. I'm going to get into this because I think it's really cool. I hope you do too, and just being a good detective. So whole genome sequencing. So we look at the whole genome pattern, the whole DNA of the TB isolate with every single case we have. Every single patient, we send an isolate to CDC to do whole genome sequencing. And we look at that whole genome, single nucleotide polymorphism, which we lovingly just call SNPs. And we do a comparison with these SNPs. And SNPs result in mutations at different positions in that DNA sequence. And the number of SNPs that differ between the isolates, so the SNP distance, can provide information about whether cases could be the result of recent transmission. So we can do genome sequencing, and it's really cool because you can really see different parts of the world have created their own kind of genome layout, right? And then we can look at these clusters, and when we see these SNPs close together, we can tell that this is recent transmission. And we can actually take these SNPs and we map them out on a tree, as you see there. And you can really diagram the genetic relationship amongst all the isolates and see the direction of genetic change. So you can actually see where there's transmission. And we do this with our outbreaks, just twofold. One, we can see that these cases are connected, and also because CDC is sending us these maps of these trees, we can actually, every now and then we'll go, wait a minute, how is that case related to our outbreak? Because we didn't know that case was related to our outbreak because they weren't caught in the contact investigation. So what you're looking at right now is we have a homegrown genotype that came out of the Minneapolis homeless shelter system, homegrown Minnesota genotype. Our demographics have been primarily male cases, long-term homelessness, polydrug and alcohol use, all US born, predominantly Black, African American, white, and American Indian, Alaskan Native. So you'll see node B is the most recent outbreak, and the last case we had was in 2017, although we believe we have a new case this year. And this is the second large outbreak with this genome. The second outbreak to reach actually CDC Lotus status. So when we reach Lotus status, we know we're in trouble because that is CDC's classification of a large outbreak of TB in the United States, which means we've had 10 cases within 3 years. And this shelter genome was resulted in an outbreak of Lotus status, which is node A that you see there, and that was in 2008. So node B started in an emergency winter shelter. We had a person who was identified with TB after the winter shelter was closed. So it made the contact investigation super hard. He'd also already spent time in jail and detox. So with him, we had a contact investigation of 180 shelter contacts, 96 contacts at the jail, both incarcerated persons and staff, and then another 18 persons from the detox center who were all contacts. So it was an extensive contact investigation in Hennepin County. A lot of work between Hennepin County Public Health and Healthcare for the Homeless, actually using the shelter database to flag contacts. So when people came into other shelters and had a TB flag on their in the database, that could be referred right over to HCMC for a TB blood test and a chest x-ray. And their contact investigation, actually, out of maybe the 800 people in EPIC at HCMC who were known to be experiencing homelessness, we probably had, over 700 of those folks with a chest x-ray and a TB blood test, which is amazing work in finding cases and getting a lot of people screened. I'll show you another example. This was another Lotus size outbreak. Is also the first MDR multidrug resistant TB outbreak this size in the continental United States. We had a source case who repeatedly sought healthcare due to chest pain, chronic cough, shortness of breath, and was misdiagnosed for 5 years. It was it was a horrid miss, and he knew he was sick. He was from an endemic country. He'd spent time in a refugee camp in Thailand that was known for MDR TB. And unfortunately, he attended a congregate setting in an adult day center. So to this date, out of this MDR outbreak, which started January 2016, we've had 19 outbreak cases. 14 of the cases were identified as contacts within 2 years prior to disease onset. 18 of the cases were also born in a high burden country, including 4 who had reported travel back homes prior to diagnosis. 15 cases were directly associated with the source cases adult day center. 18 cases had also lived in refugee camps prior to their arrival in the United States. And remember earlier when I talked about those risk factors that can increase the risk of active disease developing in those with latent infection. So in this outbreak, 9 of our cases had diabetes, 5 had kidney disease, and 1 was living with HIV. So in this MDR outbreak, we had over 550 contacts identified, which is absolutely a huge outbreak and a lot of work. This all happened in Ramsey County in the East Metro. We had 4 diagnosed with active TB as we were doing the contact investigation. So that is real good detective work. And we did so much screening in this adult day center. We actually identified 2 other cases of TB who were not connected to the outbreak. They didn't have MDR TB. They just happened to have TB, and we caught it doing the screening at the adult day center. Of those 550 contacts, we had 130 that we recommended for preventative treatment, who had repeated exposures or monitoring. The preventative treatment for drug resistance TB is actually taking moxifloxacin for 9 months, which has caused a lot of mental health issues in some patients. We had our patients, this outbreak actually happened in the Hmong community. So these were Hmong elders, and the main complaint was experiencing feelings of darkness. So of course we took folks off of treatment when people were going through that kind of effect from the treatment. So then we would medically monitor folks. So we bring people back in for active provider evaluations and chest x-rays every 6 months. We did have 67% of contacts start with the LTBI treatment after diagnosis, 64% completed treatment, which was great. And then why we did medical monitoring with the rest, we found 3 more additional cases during their medical monitoring. And then last but not least, I just wanted, this is another use of whole genome sequencing. We had a very large outbreak at Mankato State. I can say that out loud because it hit the news. And it was the source case was a gregarious, very, very outgoing person. I always say that introverts never get TB. It's always the extroverts that get TB and cause these giant investigations and outbreaks. I'm joking, of course, but he loved to party. He was an athlete. He was very involved in the community, worked on campus. And I say he loved to party. He loved to party, lots of parties in his tight little apartment with lots and lots of people. So we ended up with over 700 contacts during this investigation, 39 new cases of latent therapy, latent TB diagnosis found through contact investigation, 32 were treated for LTBI, which is 82%. And then we had 3 cases of TB found through the contact investigation, but you can see all these cases. I mean, the pink ones are the Minnesota ones, the green ones. We had a case pop up in Wisconsin. We're like, where'd that guy come from? We had another one pop up in New Jersey. We're like, where'd that guy come from? So whole genome sequencing is really wonderful because it really helps you see cases. We had a lot of these cases. Of course, he identified very few contacts, the source case. So this was all the work of an extensive investigation, which brings me back to local public health. So in Ramsey County, we had the Ramsey County TB clinic, epidemiologist, the epidemiologist at MDH helping as well. But we had a TB clinic, lots of nurses, lots of providers all involved. And then when this hit, Mankato State, Blue Earth has one disease control nurse, and she only worked probably 50% TB. And suddenly she had an investigation where she's like, I'm going to find a lot if I keep digging. As you can see, she absolutely did. But that was 700 contacts in a county that has no TB clinic and just one nurse. So a lot of resources were pulled in, boots on the ground, epidemiologists from MDH sent to help. These investigations are an enormous amount of work. And I know we're getting close to time. That was a long one. One of my favorite tweets. But time for any.
That was really great to hear that. I thought very interesting. As far as screening for TB, that's I like identifying who should be screened. For example, for anybody who comes into our MAT program, that's part of their intake labs. What other risk factors should you think about when you're just doing sort of like routine screening?
Right, that's a wonderful question. So one, you are going to see a lot more latent infection in the Native American community, just from the effect of boarding schools and residential care. We've had very sizable outbreaks on reservations. There's uncontrolled outbreaks in South Dakota. We had an outbreak on Leech Lake within the past 10 years. We've had many outbreaks on Red Lake. Cases. So we do have a population that's probably disproportionately has been affected. And then you look at your risk factors of anyone who's diagnosed with HIV should automatically be screened for TB, just because that chance of reactivating to active disease is just so gosh darn high with anyone living with HIV. Then you can really look at risk factors of, who's been in a congregate setting or experiencing homelessness, because that group living, everything from corrections to nursing homes is a great way. As we all know, we've all learned how easily airborne infections are spread due to COVID. So we really hone in on homelessness and corrections. So if you're combining factors, you have if you have a patient load that's highly Native American and has risk factors for disease progression, such as substance use, that sort of thing. I mean, you've got NACC is very unique because you kind of have all your favorite risk factors in one patient population, probably at a more disproportionately affected rate than a lot of community-based clinics. I don't know if that helped, but I mean, really zeroing in on it, definitely your HIV folks and anyone who's experienced homelessness or corrections.
Mm-hmm. And then like things like daycare settings, is that still a recommendation?
No, we're not. If we have a child with TB, like, we're on the hunt for a source, because kids naturally don't have latent TB because they just haven't been around enough to. So if we have a child with TB, there's going to be a huge contact investigation, and those contacts will be immediately identified. So we don't see when when we have TB screening in schools, it's really limited to contact investigations. We no longer recommend general TB screening in daycares or schools because the payoff isn't really there.
We're wrapping up because it's 1 o'clock. I have some more questions, but I didn't want to dominate the. So does anybody else have any questions before we officially close? And then, no? Thank you all for joining us. We'll see you in a couple weeks.